Amazing. Hi, everyone. My name is Jordan Sam. I'm a research program manager and a genomics data scientist at St. Michael's Hospital in Toronto. I do want to thank Brca and BC and Inspire Health for inviting me here to speak with all of you. It is a real honor and privilege to share the results of our studies with you and share a little bit about what we've been learning within the hereditary cancer space. That's because we do a lot of health service research, and this research is meant to benefit patients from all across the country. So I'm really excited to share all this data with you and get your exciting questions and thoughts as well. So for today, we'll be talking a little bit about the financial burdens that hereditary cancer patients face across the country. And we'll also be talking about the legal burdens and implications, in particular in regards to genetic discrimination that hereditary cancer patients across the country also experience. So for today, I'll be giving you all a brief overview of what we can do with genetics medicine today and the powers that it has in revolutionizing medicine. Then we'll dive into hereditary cancers itself and touch upon genetic discrimination in that hereditary cancer context, as well as we'll shift gears a little bit and then discuss the financial burdens associated with this condition. We'll end things off with a Q&A. I welcome any and all questions. But before we dive into hereditary cancers and genetic discrimination and all the financial burdens associated with this condition, I want to take a little bit of a step back into history. So ever since the dawn of human civilization, we've been explorers at heart. From exploring vast land masses to exploring the deep ocean to exploring new frontiers in space, humans have always been explorers. And the Human Genome Project was the first time that humans took a step within and explored who we are as a species and what makes us human. And the Human Genome Project was really revolutionary because it was the first time we were able to sequence the entire human genome. And this was a massive global effort that involved thousands and thousands of scientists all over the world. And it took 13 years to complete and costed over almost 3 billion US dollars, which probably equates like 5 billion Canadian dollars. Our economy isn't doing so great, but that's okay. So this project was really monumental within the scientific field. So why did we study the human genome? And Francis Collins was the previous director of the NIH, and I think he summed it up really nicely. In regards to the human genome, he said that it's a history book, a narrative of the journey of our species through time. It's a shop manual with incredibly detailed blueprint for building every human cell. And it's a transformative textbook of medicine with insights that will give healthcare providers immense new powers to treat, prevent, and cure diseases. And Dr. Collins was absolutely right. I mean, I'm obviously biased because I work within the field, but genetics medicine is the new frontier of medicine. It is revolutionizing the medical sciences because with genetic testing, we are now able to more accurately diagnose various diseases more quickly and more accurately. We're also able to identify individuals' disease risk even before they even develop these conditions. And we can take that one step further and identify the disease risks of these individuals' children's and their future generations, and what kind of conditions could run in the family and what those future generations' risk are. We're also able to more accurately predict the disease severity and the course of various diseases. And we're also now able to determine like what's the most appropriate medication and dosing for any given individual. For decades, pharmaceuticals has really adopted a one-size-fit-all model, meaning that, one drug works best for this one specific indication. But that as we learn more about genetics and about our human DNA, we learn that Not every single drug works well for everybody. Some drugs may work well in one person, but may not work as well in another person. But with the power of genetic testing and with advances in research within this field, we're able to identify all these topics a lot more better. And that really paves the way for hereditary cancers. So cancer itself is one of the most leading causes of morbidities and mortalities across the globe. And hereditary cancers are the most common inherited conditions. These account for up to 10% of all cancers. And you may be asking yourself, well, it's just 10%. 10% doesn't seem like a big number. When you look at the number of cancer cases across the world, that 10% turns into a really big number of patients that are impacted by hereditary cancers. If we just look at the Canadian population, for example, a conservative estimate brings up to 200,000 Canadians harboring some sort of pathogenic variant or mutation and over hundreds of genes that predispose them to a hereditary cancer. The more common hereditary cancers that you may be familiar with is hereditary breast and ovarian cancer syndrome. Certain individuals, if they carry a BRCA2 gene, for example, it could increase their lifetime risk of breast cancer of up to 80%. Some other common hereditary cancer syndromes are like Lynch syndrome, Li-Fraumeni syndrome, von Hippel-Lindau syndrome, and many more. All these hereditary cancer syndromes can impact multiple organ systems, and this is an increased cancer risk that individuals carry for the rest of their life. With the advances of technology and advances in research, genetic testing has become a lot more accessible across the country. Almost every single province offers some level of genetic testing to their patients. And some provinces, such as BC, Ontario, and so on, have their own hereditary cancer programs that provide that extra layer of specialty and care for hereditary cancer patients, whether it be through genetic counseling or consultations with medical geneticists. Patients are able to access these specialized services to understand their own cancer risk and understand their family's cancer risk and understand what kind of management and what kind of screening options are available for them. And there's lots of different genetic testing modalities out there for hereditary cancers. The ones that you're probably more common or most familiar with is gene panel testing, where clinical laboratories will look at a subset of 50 or so genes related to your personal or family history of cancer. But the future state of genetics in Canada is switching more towards genomic sequencing, where instead of just looking at a handful of genes, we're now able to look at thousands of genes. And the reason why we want to look at more genes is because we're learning so much more about our genome. We're learning so much more of how genetics can play into cancer. If you asked me 20 years ago, be like, hey, Jordan, like what kind of genes are implicated in breast cancer, for example? I'd probably tell you that's just be BRCA1 or BRCA2. But if you ask me that same question today, I'd give you a list of 50 or odd genes that have some sort of linkage to increased risk for breast cancer. So we're learning a lot more about our genetics every year, every day, and so on. So it's great that genetic testing has become more accessible and mainstream within our healthcare system. But unfortunately, that brings up the phenomenon of genetic discrimination. So genetic discrimination is the unfair, unequal treatment of individuals based on their genetic code. It's essentially when your genetic information is used against you. And the most common examples of this is within insurance settings. So for example, if let's say you're at risk for hereditary breast and ovarian cancer syndrome and somehow your insurance company found out, they may deny you access to life insurance policies, or they may deny you access to extended healthcare just because they see you as increased risk and thereby more expensive to insure you. Other examples of this would be in employment settings. Again, if let's say your employer found out you're at risk for some sort of hereditary cancer, they may wrongfully dismiss you because they see you as a liability. They may see you as something that may not be reliable enough to be around in the long term, and you may even be denied advancements within your own career. Unfortunately, there's also been instances of genetic discrimination within healthcare itself, and I'll touch upon that in a moment. But overall, genetic discrimination really limits the opportunities that patients have when they choose to undergo genetic testing, which is why it's so important for us to understand the caveats of this type of discrimination and for patients across the country to be protected. And that's when the Genetic Non-Discrimination Act of Canada comes into play. So this is a federal legislation that passed through Parliament back in 2017. And this act prohibits any person from requiring an individual to undergo a genetic test or disclose the results of their genetic tests as a condition of, providing goods or services or entering into some sort of agreement or contract and so on. So essentially, this piece of legislation protects your genetic information and prevents individuals from using your own genetic information against you. And the wording on the slide here is exactly that from the legislation itself. And it's meant to be, when it was written, it was meant to be as broad as possible so that it can also be as encompassing as possible and attempt to provide maximum protection of the genetic information of patients across the country. Unfortunately, over the years, there have been found to be some loopholes within the legislation, as many legislations, and we'll touch upon that in a moment as well. So the Genetic Non-Discrimination Act was a really great example of how research impacted health policy. And there are many individuals that we have to thank for passing this legislation in Parliament. One person I'll bring up is Dr. Yvonne Bombard. So Dr. Bombard is a Canada Research Chair in Genomics Health Services and Policy Research. She's a professor at U of T, and she's also the director of the Genomics Health Services Research Program at St. Michael's Hospital. She's also my boss. Unfortunately, she couldn't be here today, so you're all stuck with me. But she does send her regards. And the reason why Dr. Bombard was so pivotal in this legislation is because she conducted the first genetic discrimination research in Canada. And she did this with a group of patients with Huntington's disease. And the results of her research served as a scientific backbone for this legislation to be passed in Parliament. So again, this just shows the importance of research and how we can use research to positively impact health policy that not only benefits Canadians in the short term, but also benefits future generations of Canadians as well. Canada is not the only country with a Genetic Non-Discrimination Act. Lots of countries around the world have also followed suit. So for example, the US have their own version of the Genetic Non-Discrimination Act. Various countries around Europe have their own version, and Australia has their own version as well. So it just goes to show that many people across the world are realizing the importance of protecting an individual's genetic information because, this is something that you are born with, and this is not something that really changes throughout your lifetime. So it's important that we protect our genetic information against malicious intent. But just because we have legislation doesn't mean that it is always followed. So an example case of this is with Dollar General in the US. So back in 2017, it was found that Dollar General actually rescinded job offers of their employees because of their employees' personal and family medical history. And in 2017, the US Equal Employment Opportunity Commission actually filed a lawsuit, and it was found that Dollar General actually violated the Genetic Non-Discrimination Act in the US, and as well as the American with Disabilities Act. And, the short story is that Dollar General didn't want to go through a lengthy court process, so they made a settlement of over $1 million US. So this kind of segues a little bit into our research. So, that case I just showed you was in the US, but we were really interested to see, if genetic discrimination was still a problem within Canada, despite having these legal legislations. So to do that, we conducted a really large study across the country. And the goal of this study was to assess the indirect socioeconomic impacts of hereditary cancer syndrome care across different healthcare systems and jurisdictions within Canada. And again, just like the goal of a lot of our research, the goal of this was to inform policy and clinical care so that we can create, again, more legislation to further protect patients and create best practice guidelines to improve the care and access to clinical genetics for many patients across the country. And so this was a large study we conducted, and we did this primarily through our teams in British Columbia, Ontario, and in Newfoundland and Labrador. The main reason why we conducted this study across these three provinces is because, well, Ontario, because we're based in Ontario, but also in British Columbia and Newfoundland, because despite in Canada, us all being under one single public healthcare system, each province approaches hereditary cancer care very differently. For example, if we look even at the genetic testing offerings in BC versus Ontario or Newfoundland, it all kind of varies a little bit. So each province has its own approach to not just genetic testing, but the overall care pathway for patients. So we were kind of interested to see how that comes into play in the overall care of patients within this country. So this is a little bit of a busy slide. I apologize for that. But in essence, what we did is that we started off our study by doing a series of qualitative interviews. And what this essentially means is that we spoke to patients across these provinces to try to understand their experiences with living with hereditary cancers and what kind of burdens that they face on a daily basis with this condition. Because like I mentioned earlier, hereditary cancer is, it's a lifelong journey. It's something you're unfortunately born with and something that individuals carry for the rest of their life. So we were interested in understanding what that story is for patients. And from using that data, from that qualitative work, we use that to inform the development of our survey, which we launched across the country. And the purpose of that survey was to now quantify the impacts of hereditary cancers. And I'll touch more upon that survey in a moment as well. So in terms of the qualitative work, we spoke to 73 patients across the country. About half of those patients had hereditary breast and ovarian cancer syndrome. The other half had Lynch syndrome. We spoke to a wide range of ages of patients, as young as patients in their mid-20s to as old as those that are retired in the 60s or 70s. Majority of our patients that we spoke to were female, and we tried to achieve as much diversity as possible when it came to ethnicity. But unfortunately, with many genetics research, it is still biased towards those of white or European background. And our sample was also rather highly educated, so many individuals having education beyond high school. So here's just a snippet of our data. I won't go through everything. I'll just focus on two main key pieces for this talk. Well, when it comes to the healthcare system, we found that lots of patients experience challenges within the healthcare system. From the outside looking in, especially when I speak to my counterparts in the US, the Canadian healthcare system is kind of glorified. It's great that we have a free healthcare system, but definitely has its limitations. We find that lots of healthcare providers are unaware of what hereditary cancers are and what the care pathway is for patients. And that leaves patients having the need to self-advocate for their own health and figure out what they need to do in order to access screening, in order to access all these additional services that they need to monitor their hereditary cancer risk. So for example, one patient in BC said that it's overwhelming because none of these systems seem to be integrated and none of them are at automatic recalls for these tests. It's basically me coming down to myself using my iPhone to schedule. So it just highlights the disconnect that our healthcare system has when it comes to providing high quality care for patients. A lot of patients have experienced degrees of psychosocial impacts and mental health tolls. Again, like I said, like this is a lifelong journey. And, if you imagine a young 20-year-old finding out they're at risk for a hereditary cancer, that can have profound effects on their own psychosocial health. For example, one patient from Ontario said that if I ever got sick, I immediately thought it was cancer and it caused a lot of stress and anxiety. Lots of patients have also made lifestyle changes, more particular in diet and just having that active lifestyle in attempts to curb or mitigate any of their cancer risk. And lots of patients experience financial impacts, which I'll talk about in a moment. And unfortunately, there's lots of reported instances of genetic discrimination within our patient population. And I'll talk about that next. So amongst all the patients we spoke to, they've faced genetic discrimination because of their hereditary cancer in multiple settings. The first setting is within healthcare itself. Although patients themselves weren't, you know, actually discriminated against, they had that felt stigma of being stigmatized because of their hereditary cancer risk. A lot of patients described experiences where the lack of knowledge from their healthcare providers promoted harmful assumptions about their hereditary cancer risk and their care needs. So, for example, one patient in Newfoundland said that this young guy came in, a medical student, and we were talking about the genetic mutations. And he said, "So who in your family married another family member?" And I was really taken back. That was a real learning curve for me because up to that moment, I never thought that other people could think that was the reason we had this gene. So it just shows that, the lack of knowledge amongst hereditary cancers, even within the medical field, really has a negative consequence for patient care and comfort when relying on physicians to serve as their champions in their health. And the more obvious example of genetic discrimination is within insurance. I gave you all a hypothetical situation earlier, but the hypothetical is not always a hypothetical. A lot of patients have described experiences of receiving lesser coverage and paying higher premiums for the same coverage and receiving coverage denials because they revealed their hereditary cancer risk to their insurance companies. And, insurance companies can't directly ask you for your genetic information. But if it is something that you voluntarily disclose to them, then that could have dire consequences to your own coverage. So, for example, one patient in Ontario said that, so I get life insurance through work, and I have to let them know about the genetic condition. It was a pretty significant change in the money in the life insurance and how much they would cover because I have a genetic condition. And again, hereditary cancer patients still face that genetic discrimination in employment settings as well. A lot of our patients said that they felt stigmatized because of having to take those leaves of absences from work for their screening. Again, like I mentioned many times before, this is a lifelong journey for many patients, and that will require, you know, constant screening, annual mammograms, maybe more than once a year, or colonoscopies, or any other type of screening or monitoring program to stay on top of their risk. And that means taking time off work. And sometimes a lot of people who do not understand what hereditary cancer patients go through, um, they patients feel kind of discriminated against because no one really understands their burdens. So, for example, one patient said that it feels like there's a bit of a stigma when you're taking these leaves and nobody knows why you're off. And you feel like people are maybe assuming things about you that aren't true. Another example of this was within professional opportunities itself. A lot of our patients describe fears of not being able to secure employment or being passed over for promotions or facing wrongful termination or forced retirement because of their hereditary cancer risk. So again, other patients said that for the most part, I haven't told my employer. I don't want anyone to walk on eggshells around me. I don't want anyone give me special privileges because if I couldn't do this job, then maybe I should reconsider something else. And unfortunately, a lot of hereditary cancer patients also face genetic discrimination within their own families and within their own social groups. A lot of patients said that they were hesitant to share their hereditary cancer risk with their family, friends, and acquaintances because they fear that judgment from their family or being stigmatized within these settings. So, for example, one patient in BC said that in relation to her partner's family, she said that it scares them if they know that I have a cancer gene. I mean, they're worried about my genes mixing with their gene and things like that. So it is quite unfortunate that a lot of hereditary cancer patients face stigma in these settings as well. In terms of the Genetic Non-Discrimination Act itself, lots of patients, if they are aware of it, they do see it as valuable legislation to protect their genetic information. And many patients appreciate this legislation protecting them against malicious intent from third parties. But unfortunately, not a lot of patients understand what the Genetic Discrimination Act is and what its terms and conditions are and its limitations. But one patient from Newfoundland said that, so thank goodness nowadays that they're not allowed to ask that question. So patients can continue on to get coverage. And that's a real bright spot for anyone that has families with genetic mutations. And I touched upon this already, but many patients just don't understand the Genetic Non-Discrimination Act to its full intent. And I see that's kind of fair because, it's a piece of legislation, it's a lot of legal jargon, so I always recommend you speak to a lawyer about it. Um, but because of the lack of knowledge and understanding of the Genetic Non-Discrimination Act, a lot of patients don't know how to approach their genetic information. They don't know if they should be disclosing this to their insurance companies or their employers or so on. So, for example, one patient in BC expressed their confusion with this, and they said that I can't remember if the insurance company asked about the BRCA2 gene specifically, or they might have asked, "Have you ever been checked for hereditary cancers?" But I don't know that they actually came out and said, "Did you test positive?" They have their roundabout ways of asking. So this patient brings up a really great example of one of the loopholes within the Genetic Non-Discrimination Act. Yes, insurance companies specifically can't ask you about your genetic information, but they have their roundabout ways of questioning and coming to their own conclusions. So they may ask for your family history. If they find out, you have a couple of generations of breast cancer, they might come to their own conclusions that you are at increased risk. Or if they find out you go for mammograms more frequently than the average individual, or you start these early surveillance programs much earlier than an average individual, then they might start to connect those dots. So it's always important to protect your own health information and be careful of who you share your medical history or medical information with. So if you ever do experience acts of genetic discrimination, there are many places where you can report it. It is federal legislation, so you could report it to the RCMP, you could report to your local police force. If this act of genetic discrimination involves a federally regulated sector, such as airlines or banking, you could report it to the Canadian Human Rights Commission. But if it affects more provincially regulated sectors, then you could speak to your provincial Human Rights Commission. So, for example, in BC, they have their own Human Rights Tribunal. So I'm going to shift gears a little bit and talk about the financial implications of hereditary cancers. But before we do that, we got to talk about cancer itself. So like I mentioned earlier on, cancer is the leading cause of morbidities and mortalities across the world. And unfortunately, cancer is also one of the most expensive conditions to treat. There's lots of stories in non-public healthcare systems, like in the US, where patients go bankrupt over their cancer treatments, or they have to choose between undergoing cancer treatments or paying rent or paying for groceries and things like that. And it's been reported that over 75% of cancer patients face significant financial hardships. And this can really impact, as you can imagine, someone's quality of life and really cause them a lot of distress. So this understanding of financial toxicity in cancer is really well understood in the literature, and everyone is really well informed of its financial implications. But what we don't really know much about is the financial toxicities of hereditary cancers itself. So which was also one of the big goals of our research project. So lo and behold, financial toxicity still also exists in hereditary cancers. And I'm going to break it down a little bit, so I'm going to throw you a couple terms. But we find that hereditary cancer patients face significant objective financial burdens. So these are the tangible financial costs associated with hereditary cancers. These are the actual out-of-pocket costs. And we also find that patients face significant subjective financial burdens as well. So this one may be a little bit hard to understand, but it's the intangible financial burdens that patients face. And we'll explore this a little bit more in a moment. But in terms of the actual direct financial burdens, we find a lot of patients still experience direct medical costs. Now, our healthcare system is great because it's free, quote unquote. We still pay high taxes, but we don't have massive medical bills every time we see a doctor. But despite that, despite the coverage within our healthcare system, a lot of patients still have to pay for these over-the-counter medications. If patients chose to undergo risk-reducing surgeries, such as prophylactic surgeries, they may have to undergo physiotherapy, and that's usually out of pocket. A lot of patients may also have to undergo psychotherapy and seek additional mental health counseling. Because like I mentioned a couple slides ago, this is a lifelong condition, and disclosure of these results could be really impactful to a patient. So seeking that mental health and support is sometimes necessary. And unfortunately, a lot of patients have to pay for that out of pocket. And again, if patients undergo those risk-reducing surgeries and they still want to, at a young age, and if they still want children in the future, they may have to undergo expensive fertility treatments. So it's that grappling between reducing your cancer risk, but also wanting to have your own family, which can be expensive. A lot of patients also describe lots of non-medical costs. So this includes travels to medical appointments, and we'll touch more about that later on. And a lot of patients also pay a lot to change their diets. So again, especially folks with Lynch syndrome, a lot of them have reported wanting to have healthier diets to curb a lot of their cancer risk. And one patient from Ontario said something that I found to be really impactful. And they said that, "I'm happy we live in a country where it's free healthcare, but that free healthcare has its limitations." And lots of patients face indirect financial burdens. So this really stems from productivity loss. So again, taking that time off work to go to these appointments could result in income loss. And in a couple slides, we'll quantify that. A lot of patients describe changing their careers to have something less stressful because they're already dealing a lot in their own personal life. And lots of patients describe changing their frequency in work, switching from full-time to part-time because again, they have a lot going on in their personal lives. Or many individuals chose to retire early because they decided they want to live life to the fullest and not have to worry about not enjoying life because of their diagnosis. And things like traveling to appointments and stuff and paying for gas and all that, it's expensive. And one patient from BC said that it's expensive to drive there given gas prices and having to take time off work, so it's expensive for sure. It's cost and time and money to get there. But I mean, I don't know what the alternative would be, right? And you may And some people may see this and be like, well, gas is, a couple buck, like a buck something a liter, so it's not too bad. But, a CTV report came out last year saying that half of Canadians are living paycheck to paycheck. So that extra trip to a doctor's office or taking that extra day off work and losing those wages could be make or break for lots of families across the country. And patients face a lot of subjective financial burdens. So again, these are a little bit more intangible. So for example, when it comes to decision making, when we take prophylactic surgeries or risk reducing surgeries, for example, paying for these surgeries in Canada is no cost to us individually, but the downstream effects of undergoing those surgeries could be expensive. It could impact someone's ability to work down the road, and all these have financial implications. And just living with that financial uncertainty of these hereditary cancers is significant to a lot of patients, especially because this is a cancer risk. It's not a guarantee that someone develops cancer, even if they have a genetic predisposition. It just means that they are at much higher risk compared to the general population. So one patient from Ontario kind of summed it up really nice, and he said that, well, how can I best position my family and children so they're not dealing with financial hardship or burdens if something was to happen to me? So we took the data from all that qualitative work and we really fed that into a survey and to help us develop that survey. And the goal of this survey was to start to quantify the impacts that hereditary cancer has for patients across the country in terms of their own care as well as their finances. So we distributed this so for the survey we had responses from all over the country, not just the three provinces that were mainly focused on, but we've had responses from folks from the Yukon, folks from Alberta, Nova Scotia, Quebec, and so on. We've had the survey open for over about a year, and we just closed it. But we've achieved over 1,000 responses from patients all over the country, which is really phenomenal because our original goal was 600, so we definitely surpassed that. And we distributed this survey across clinical cancer clinics within BC, Ontario, and Newfoundland. But we also distribute the survey to local and national patient support groups such as Brca and BC. So some of you may have seen it. And we relied on snowball sampling a lot as well. So, patients giving it to other patients they know or giving it to family members. So we collected all those responses. So just some really quick stats for you in terms of like what our sample looked like. Majority of our sample, the mean age of our sample is about 55. Majority were also women. Almost a third of our sample came from individuals with hereditary breast ovarian cancer syndrome. About 22% came from those with Lynch syndrome, and the rest came from various other hereditary cancer syndromes. Majority of our sample would come from individuals of wider European background. Many individuals had education beyond high school. And about half our sample lived in urban environments, so big cities like Toronto or Vancouver. And about the other half of our sample came from individuals living from more rural or more medium-sized cities. So when it came to our survey, we were thinking about how we can split this up. And we looked at two main pieces of data. And we looked at first access to care, and then we looked at patient supports. So we found that within our survey, we found that about 32% of individuals belong or had low access to care. And when I say low access to care, I mean individuals that did not have sufficient help from their healthcare providers, had to wait a really long time for their appointments, had difficulties getting their appointment, and really had to self-advocate for their own health. And, individuals belong to high access to care group would just be the opposite of that. But it was kind of alarming to us. Again, we glorify the Canadian healthcare system, and the healthcare system is great when you compare it to many other healthcare systems across the world. But the fact that a third of our samples still had low access to care was still quite shocking. And we also looked at patient support, so whether or not patients were supported by the healthcare system. And we found, again, almost a third of patients were lowly supported by the healthcare system. And when I talk about low support, I mean patients that did not have knowledgeable healthcare providers or had poorly communicative healthcare providers and did not have access to additional healthcare resources that they needed. And so again, like these numbers were kind of shocking to us. It was obviously very interesting, but it was a little bit disheartening to see that our healthcare system is not as good as we wanted it to be. So we took those individuals, those low access to care individuals and those high access to care individuals, and we asked ourselves, what are the financial hardships that these groups of individuals may face? So we found that if you look at the total financial burden at the bottom there, on an annual basis, individuals with low access to care have out-of-pocket expenses of $1,340 Canadian per year. If you contrast that to individuals with high access to care, they have about financial burdens of about $579 per year. So in essence, people with low access to care pay about $993 more per year for care versus those that have high access. So it just goes to show that how important it is for us to provide high quality and high access care for patients all across the country. Because if we do not, then patients do have significantly more financial burdens. And if we look at the levels of patient support, and again, if we look at the row at the bottom there, we find that patients that are lowly supported by the healthcare system have an annual financial burden of $1,533 versus those that are highly supported by healthcare system having a total financial annual burden of $545. So again, it's the same narrative of um, patients lowly supporting the healthcare system having to pay that extra $975 per year. And again, that same narrative of, the need for providing high support for patients across our country. And we looked at a couple other things as well that we also found to be pretty interesting. So we found that for every year increase in age, the financial difficulties of patients actually decreased by 4%. And that kind of makes sense, Let's say a young individual in their early 20s, they would probably face a lot more difficulties when it comes to the finances of their hereditary cancer versus someone in their 40s that may have their own established career. We also find that people living in large urban areas, so like again, cities like Vancouver, Toronto, or St. John's have a 47% lower chance of financial difficulty. And again, our hypothesis is that, the big hospital institutions, the big cutting edge research, and the highly funded clinics are all found in big urban cities. And if we take Toronto example, University Avenue has four world-class hospitals, all just in one street. Um, and then when we look at income, we find that, obviously people that earn over $200,000 a year have 64% lower odds of having that financial difficulty in terms of their hereditary cancer. And individuals with income less than $40,000 per year have, 2.3 times higher odds of financial difficulty in terms of their hereditary cancer. So that was all about hereditary cancer, but when we look at the cancer itself, remember how I told you that cancer is one of the most expensive conditions to treat. And we find that patients that actually had cancer, they have about 2.6 to 3.8 times higher odds of financial difficulties versus those that don't have cancer yet, those that just have a risk, so those that are previvors. So that cancer diagnosis really does jump things a little bit. So just a couple take-home messages for you. Genetic discrimination still exists across various settings in Canada. We have the Genetic Non-Discrimination Act, which does provide you legal protection of your genetic information. But of course, it has its limitations. Like again, with the insurance company examples, insurance companies do have their roundabout ways of figuring out if you're at risk for a genetic condition. So you should be careful of who you share your health information with. And I'm not a lawyer, obviously, so I can't give you legal advice. But if you feel that you've been in situations like this, I would definitely recommend you speak to a lawyer. And in terms of the financial piece, our healthcare system is great. It's, free in some regards, we do pay those high taxes, but it's great because we don't have those big medical bills at the end of the day that can really make or break many families, as we see many examples in our counterparts in the US. But that doesn't mean that, patients across the country don't face these significant out-of-pocket expenses. So, whether you have a new diagnosis or if you have your diagnosis for a while, it's always good to be prepared for any unexpected costs and put some extra money aside per year just to, handle any costs associated with your hereditary cancer. And I'll end off with with one note here saying that saying about the importance of patients in research. Now, especially in health research, patients are at the center of it. The reason why we do all this research is to benefit patients across the country. And Dr. Holly Etchegary, who is one of the co-principal investigators in the study, she said that the public, as users of the healthcare system, patients, should be heard. The opinions and concerns of the ultimate end users of sequencing technology should have a voice in how sequencing is used in our province. So it is a big collaborative effort in research when it comes to researchers and patients. So I always recommend to get involved in research if you're able to. And that kind of segues into my little plug here. But we have many research studies going. If you ever did want to participate in research yourself, either as a research participant or as a patient partner, there's lots of institutions across the country that are doing really cutting edge research. So I definitely would recommend you reach out to them. But in particular for us, I'll just briefly mention two of our ongoing research studies. One, we're looking at the equity and diversity within genetics research itself. Historically, research has been underrepresented in many different ethnicities. So our goal is to develop best practice guidelines so that we can do more equitable research within genetics, so that we can benefit all patients, regardless of their identity across the country. So if you do identify as a person of color or know someone that identifies as a person of color and you're interested in participating, we'd love to speak to you and understand your perspectives as a research participant. Another study that we're looking at is genetic testing and within families and relatives. So we really want to explore the needs and preferences of patients and their relatives across the country in terms of genetic testing. And we are developing digital tools here at St. Michael's in collaboration with Women's College Hospital to expedite and increase access to genetic testing across the country. And we'd love if you love to participate in this research study, definitely reach out and we can be in touch. So that was a lot of me speaking. I apologize for that. But I do want to thank all of our collaborators across the country. That was really pivotal in help in allowing this research to happen. Of some of these names here you might recognize, such as Dr. Kesminton Schrader, who was also one of the co-principal investigators on this project, along with Dr. Ron Bombard and Dr. Holly Etchegary. And at the bottom right here, you can see all the patient partners. Again, some names you might recognize. Patient partners have been really valuable in our research and providing us with that guidance through their own lived experiences. As researchers, we can read about hereditary cancers all we want, but it's different when you live with these experiences. So patient partners have been really important in helping us shape our work and help us understand the results a little bit better so that we can provide these more meaningful results and having that end goal of developing policy to better improve the access to care of patients all over the country and to serve as a model for other healthcare systems around the world. So that's it. And I'm happy to take any and all questions.
Thank you so much, Jordan, for that great presentation. And just before we dive right into the Q&A, folks, I think Katrina has a few pieces to add just to complement that wonderful presentation. So handing it right over to you, Katrina, before we pause the recording and dive into the Q&A.
Sure. Thanks so much, Jordan. It's a real privilege to hear and see this study coming together. I am listed as a patient partner. I was lucky enough to be on the email thread when this funding was originally announced. I remember the excitement around it, and it's just really amazing to see a few years later all that your team has accomplished. And it's really, really important work for this community to hear about and to see what, what the scope of the issues are. That's what ultimately, gets more funding towards issues like supporting carriers and making sure that we address any gaps in things like the Genetic Non-Discrimination Act and ensure that we can help those insurance companies get a little more educated on why this information it should not be feared, but in fact should be encouraged. I just wanted to ensure folks were aware of a couple of new resources that BRC and BC has been in the works of developing alongside a law firm, Taylor and Blair, as well as one of our community engagement manager also happens to be a graduating law student. And so she was working very hard this last year on creating a blog article that would help community members, people who do carry a mutation, if they should face any issues of genetic discrimination. So once the chat is up, I will pop a link to that blog in case you haven't seen it. And I don't think it's online yet, but Taylor and Blair themselves also actually developed their own companion blog, and I've been lucky to have a read through it, and it's a really, really good explanation of the Genetic Non-Discrimination Act, things you need to know, how it might affect insurance, things you can say, what you can get away with not saying. So it's a really, really useful companion to the piece that we've written, which ours is really focused on what do you do should you come up against, one of these issues, and then, what are the escalating levels of engagement that you might need to consider, as well as who the resources are. So we give you all the links to everyone you'd want to connect with potentially should you need to deal with an issue on your own. But yeah, that companion blog is really useful, as well as knowing that Taylor and Blair themselves have identified themselves as a resource to our community. So they are specialists in insurance denials, and they have made it their business to become well-versed on the Genetic Non-Discrimination Act and supporting patients in British Columbia who are facing genetic discrimination issues. So we will have links to their information on that blog and in that resource. So I will share that with all of you. And now I will be quiet and hand it back to Jordan for the Q&A.